A woman starts having cognitive symptoms, confusion, some personality changes, things that feel off. She's told that it's menopause and anxiety. Her family pushes for more answers. It takes a while, and when they finally get them, the diagnosis is incurable brain cancer. This story is not rare in the way we want it to be, and it's worth sitting with.
Hi there, I'm Tony Lee, and this is Hot Flasher, your daily menopause podcast that serves up fresh news, research, and wellness tips. I've built a daily news pipeline to find the latest on women's health and menopause research. Allow me to introduce my co-host, Nikki, who handles the headlines. Take it away, Nikki.
Thanks, Tony. We've got a lot to get into today, so let's go. The People.com story about a mum whose confusion was dismissed as menopause and anxiety and who was eventually diagnosed with incurable brain cancer is the kind of story that should make every woman reading it feel something between grief and recognition. Because the dismissal part, it's probably just menopause, it's probably just anxiety part, that's not a freak occurrence. That's a pattern with a body count. Here's what happened as reported. This woman's family noticed cognitive and behavioural changes. Things felt off. When they brought it to the medical system, the working explanation was menopause and anxiety. It took persistence, her family pushing, asking questions, not accepting the first answer, before they got to the actual diagnosis. Glioblastoma, incurable. Now, I want to be careful here because I'm not saying menopause causes brain cancer, and I'm not saying that every doctor who considers menopause in a differential diagnosis is doing something wrong. Menopause genuinely does cause cognitive symptoms. Brain fog is real, mood changes are real, verbal recall issues are real, so clinicians aren't wrong to consider it. The problem is when consider it becomes assume it and the workup stops there. When a woman is in her late 40s or 50s and she's confused or seems different, menopause gets to sit at the top of the list in a way it wouldn't for a man with the same symptoms. And that's where the system fails her. The research on this is uncomfortable. Studies on diagnostic gender bias consistently show that women's symptoms, particularly neurological and cardiovascular ones, take longer to get a serious workup, get attributed to psychological causes at higher rates, and are more likely to be met with watchful waiting than aggressive investigation. There's a phrase that shows up in this literature: atypical presentation. Women present atypically for heart attacks. Women present atypically for strokes, except they're not atypical, they're just women. And the baseline was built around male patients. The same dynamic plays out with cognitive symptoms in midlife. What makes this story particularly hard is that there's no clean fix to offer. Glioblastoma is aggressive regardless of when it's caught. But the timeline of diagnosis matters, and so does the experience of being believed. This woman's family had to fight for that. They shouldn't have had to. My actual position on this: she's perimenopausal should never be the end of the diagnostic conversation for cognitive or behavioural changes. It should be one hypothesis in a differential that also includes neurological causes, cardiovascular causes, thyroid dysfunction, and yes, sometimes psychiatric ones too. If a clinician tells you it's menopause and you don't feel right about that answer, you are allowed to push. You are allowed to ask what else it could be. You are allowed to request a referral. The burden of advocacy should not fall on patients and their families, and it currently does, and that's a failure of the system, not of the women navigating it. Something completely different, and something that I'd bet affects more listeners than realise it's connected to menopause at all. Waking up at night to use the bathroom. The formal term is Nocturia, waking one or more times per night specifically to urinate. A new practice, Pearl just published in the journal Menopause, which is NAMS's journal, goes into the physiology of why this happens so much more in postmenopausal women. And honestly, I found myself going through it thinking, why is this not talked about more? Because here's what women usually hear when they bring this up. Oh, that's just getting older. Or sometimes, try not drinking water after 7 p.m. And those responses are not wrong exactly, but they're nowhere near complete. What the NAMS piece lays out is that nocturia in postmenopausal women is driven by a convergence of factors that are specifically hormonal and physiological. Estrogen and progesterone affect bladder capacity, urethral tissue, and the pelvic floor. When estrogen drops, the bladder mucosa becomes less elastic. The urethral tissue thins. This is part of the genitourinary syndrome of menopause, GSM, which gets a lot of coverage for its effects on sexual health, but less for what it does to urinary function. There are also shifts in how the kidneys concentrate urine overnight, a process called nocturnal polyuria, which can become dysregulated post-menopause. And then layer on top of that, if you're already waking from vasomotor symptoms, a hot flash, night sweats, your brain is aroused enough to notice a bladder that wouldn't have woken you otherwise. So nocturia in postmenopausal women isn't one thing. It's a stack, and treating it as just you're getting older and your bladder's weaker misses most of that stack. The downstream effects are worth taking seriously. The NAMS piece flags sleep disruption, which, if you're already dealing with menopause-related insomnia, you do not need more of. But there's also cardiovascular risk in the mix. Fragmented sleep is associated with elevated blood pressure, impaired glucose metabolism, and increased cortisol. So nocturia isn't just annoying, it's a symptom that compounds other menopause-related health risks if it goes unmanaged. What can actually be done? The practice Pearl reviews several options. Genitourinary symptoms that are driving it may respond to local estrogen therapy, low-dose vaginal estrogen, which has a very different risk profile than systemic HRT and is specifically indicated for GSM. Pelvic floor physical therapy is evidence-supported. Behavioural interventions, and I mean real ones, not just drink less water, but timed fluid management, positioning, bladder training, have data behind them. For women with nocturnal polyuria specifically, there are pharmacological options your doctor can discuss. The larger point, if you are waking up 2 or 3 times a night to use the bathroom and you have been writing it off as aging, it is worth bringing up with whoever manages your menopause care. Because it may be a treatable part of what's happening hormonally, not just an inevitable part of getting older. Those are different things. The third item is lighter, and I'll give it the proportional weight it deserves. Eating Well ran a piece about a new study suggesting that a specific drink, green tea, based on the underlying research they're referencing, may help lower cholesterol in postmenopausal women. The angle is cardiovascular. Estrogen's decline post-menopause shifts the lipid profile in a direction that increases LDL and decreases HDL, which raises cardiovascular risk. That part is well established. The question is whether green tea does anything meaningful about it. The study they're citing, and Eating Well is a consumer outlet, so they don't go deep on methods, which means I'm going off what's reported, appears to be relatively small and dietary intervention based. That category of research has a consistency problem. The biological mechanism is plausible. Green tea contains catechins, particularly EGCG, which have demonstrated effects on LDL oxidation and cholesterol synthesis in lab settings. There are meta-analyses, including one published in the American Journal of Clinical Nutrition, that find modest reductions in total and LDL cholesterol with green tea consumption, roughly 2 to 6 mcg/dl depending on the study. That's real, but not dramatic. My read: if you already drink green tea, this is reassuring. If you don't drink it and your postmenopause cholesterol panel is looking rough, adding green tea is a low-risk move with some evidence behind it. But it is not going to substitute for a conversation with your doctor about lipid management if your numbers are significantly elevated. And the headline, "This drink could help lower your cholesterol," is doing a bit more heavy lifting than the underlying data probably supports. That's what health journalism does with dietary studies, and it's worth naming. What I think is actually useful here is the reminder that post-menopause cardiovascular risk deserves active attention. Cholesterol monitoring, blood pressure monitoring, understanding your own lipid profile and what's changed. This is the kind of thing that often falls through the cracks because midlife women are focused on the symptoms they feel, not the risk factors accumulating quietly. The estrogen decline that drives hot flashes is the same decline that changes how your body handles fat metabolism. They're connected. And if your last lipid panel was pre-menopause, it might be time to get an updated picture.
Thanks for listening to Hot Flasher. We're back tomorrow with more, so don't forget to subscribe. See you tomorrow.